the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice.
Welcome back, listeners. Today, we have the pleasure of having one of our student scholarship winners from 2024 on the podcast. Graham Parks is a PA student from the University of Kentucky. Graham, thanks for being on the podcast.
Yeah, thank you for the introduction and thanks for having me. I'm happy to be here.
As you may remember, the PAOS Foundation awarded 4 $5,000 scholarships to PA students this year. Graham's case study, a research review of Subscapularis-sparing Approach for anatomical total shoulders, earned him a spot as one of the 4 finalists and a scholarship winner. This review analyzes existing literature for total shoulder arthroplasties, introduces the Subscapularis-sparing Approach, and compares postoperative outcomes with the standard approach. Graham, please tell our listeners about the Subscapularis-sparing Approach and your experience with it.
I was introduced to the Subscapularis-sparing Approach when I was working as a surgical assistant prior to PA school. So after my undergraduate studies, I worked at Baptist Health Lexington for about a year and a half with some total joint replacement surgeons for the main part, where I held retractors for them and just helped them, maintaining sterile field and stuff like that, kind of like a first assist. And I worked with Dr. Hackett and Dr. Kirk and Luckett, who Kirk and Luckett were knees and hips, and Dr. Hackett was mainly shoulders. And so I occasionally worked with him, and he was starting to use the SSS approach kind of towards when I was leaving. So I saw a few of them, but not as much as I would like to have scrubbed in. But overall, the SSS approach is fairly similar to a standard anatomical total shoulder. The main difference is in the exposure of the surgical site. And if you're familiar with the anatomical arthroplasty, the subscapularis must be peeled back at its insertion on that lesser tuberosity of the humerus to expose the site, and then it needs to be repaired after implantation of the components. And so that repair requires some immobilization of the joint for up to 6 weeks and about 6 to 12 months for complete recovery. And this new approach, the SSS approach, is using that same deltopectoral incision, but it exposes the joint by creating a window in the inferior joint capsule just above that muscle belly of the subscapularis. And so a specialized retractor is then used to keep the subscapularis out of the way, and then standard cuts on the humerus are used and standard components are implanted. The main challenge with this approach is the reduced exposure. It's a bit of a tight fit. That's mainly the rundown of the SSS approach.
You mentioned in the study that rotator cuff tears occur after total shoulder arthroplasties and can contribute to surgical failure. How often does this happen, and what symptoms do the patient typically present with?
So there's a lot of varying literature out there for rotator cuff tears, specifically in dysfunction after surgery, but for rotator cuff tears and component failure, I found one study that reported about 17% of anatomical shoulder patients had a postoperative rotator cuff dysfunction at about 10 years follow-up. And then another study reported that approximately 30% of patients presented with superior migration of the humeral head on X-ray at about 7 years follow-up. And that superior migration can be indicative of rotator cuff dysfunction or tear. But complete tears are relatively rare postoperatively. But it's important to add, some literature and recent reports have shown that there's an increased difficulty in diagnosing rotator cuff tears. So there may be a lot that go undiagnosed that may be preventing to that component failure or loosening. So that's something that needs to be researched more. But basic symptoms of rotator cuff tears that one might notice after surgery, pain, especially with overhead movements, a dull ache that worsens throughout the day and is especially difficult to sleep on, and then popping or grating sensations in the joint, and then that component loosening and instability that I mentioned.
You mentioned in your presentation that shoulder elevation and internal rotation were marginally statistically insignificant between the groups, which was quite interesting. This is one outcome from the study, and if we just looked at this, we might think that the subscapularis-sparing approach would not benefit our patients. What were other outcome benefits that you found outside of this?
Right, so that study that you're mentioning, the insignificance between groups was really looking at postoperative movements. when compared to the regular anatomical approach. And so what that means is basically that the subscapularis-sparing approach does not produce worse or better mobility postoperatively. It produces pretty similar mobility results. And when it comes to shoulder elevation and external rotation. And the important variation between the approaches is that recovery time that I've mentioned and the potential reduction in revision surgeries. So if we don't have to violate the subscapularis insertion, then we don't have to repair it. And there's little to no risk of it being torn postoperatively. And then there's a fraction of the time in a sling, there's shorter physical therapy, there's less time to return back to daily activities, sports, etc. And being immobilized for less than a week and shorter PT can make a huge difference in quality of life following that shoulder replacement. And as you said, like people worry about driving or doing things around the house after they get the surgery. Those activities can be returned to in as little as a week or so. So that's the big caveat with this approach. And there's no limitation for internal rotation because you're not removing that subscapularis. So you still got your big internal rotator of the humerus. So that's really what we get out of this approach for the most part. And then it doesn't produce worse outcomes with mobility. So the anatomical approach already has some great postoperative mobility after that rotator cuff heals. So we see similar results mobility wise.
This technique was introduced in 2009 and has not become the standard for total shoulder arthroplasties. Why do you think this is?
So right off the bat, it's challenging. It's physically challenging for the surgeon and the surgical team. And like most new approaches, it's going to take a lot of practice. And with that limited exposure or smaller window for the components, it can be difficult to see the joint space when compared to the standard approach. And one big concern with that limited exposure is ensuring that removal of osteophytes have been complete. So it's important to be thorough about that when using this approach. But like I said, most things, it takes practice. And I think the learning curve and increased operation times can make some people apprehensive about adopting this approach. But surgeons will tell you, Dr. Hackett will tell you that as you familiarize yourself with this technique, the operative times come back down to average and you become more comfortable with component implementation, just like any new approach.
Are there limitations to this approach? Is patient selection important?
Patient selection is certainly important. It's easier to use this approach on a healthy patient. You need to have an intact rotator cuff for this approach. To my knowledge, anyone that doesn't have an intact rotator cuff, you probably just use a reverse TSA approach anyway. So there's that. And then exposure is going to be more challenging for very muscular, kind of stocky patients or patients with higher BMIs. So with the limited exposure that the approach itself creates, then having more muscle or more adipose tissue around the joint is going to make it even more challenging. So that's the main limitation with this approach, but it's certainly possible. And I think it just takes time and watching other surgeons, watching other surgical teams use this approach. There's plenty of videos on like ViewMedi and stuff like that you can see. And Dr. Hackett himself is very open to teaching people that want to come watch him. So that it's really just kind of getting the word out and getting more research around it. I think it's really beneficial to the patient, even if it provides that steep climbing curve at first. I think that this is something that could really change the game for total shoulder replacements.
What was it like to be at the conference in Nashville?
The conference was a wonderful experience. I was very grateful for the opportunity it was my first conference that I've been to. It was super informative. I was able to learn so much about not only what it means to be an orthopedic PA, but just becoming a PA in general as I'm still in school. And the latest news in the orthopedic world was very eye-opening. I had some experience in orthopedics prior to going there, but I just learned so much more outside of my baseline. And it was definitely rewarding to meet people that share my interest and passion for orthopedics. And I think I made a lot of great connections and got a lot of good advice. So I was really happy with it.
Thank you so much for taking time to come onto the podcast. Again, congratulations for winning one of the 2024 student scholarships.
Thank you. Yeah, thank you so much for having me.
Thank you for listening to the orthoPAC podcast. The Susan Lindell Memorial Scholarship Fund is an arm of the PAOS Foundation, and donations are tax deductible. Learn more about helping future ortho PAs at paos.org/scholarships.